Hi everybody, good afternoon. My name's Lisa Grant, I'm the Chief Nurse at the Trust. Welcome to Friday Report Out. So Julian is having some well-deserved annual leave, so you have me for this Friday's Report Out, and it's great to welcome the Surgical Assessment Unit for their value stream virtual RPIW Ultrasound Scanning 60-day Report Out. So over to you guys.
Thank you. Hi everyone, my name is Aman. I'm one of the consultant EGS surgeons that started with the Trust last October as a consultant. I am presenting the report out for our RPIW. This was our project. The week was second week of June. We were focusing on the ultrasound pathways for our new ambulatory surgical services arranged through the ambulatory clinic up in Chancellor Wing. This was the first virtual RPIW that was held. We had a good mix of team members, including surgeons, consultants, junior doctors, support workers, ward clerks, as well as radiographers. I was the process owner, co-process owner, along with Simon Burbage, who's a consultant radiologist, who is on leave and unable to join us today. We focused on the pathway for ultrasound scans for patients attending the ambulatory surgical unit. We wanted to make the process favorable for patient and from a patient experience point of view, as well as improving staff experience with these processes. Next slide, please. Looking at our target progress report, we'll talk about some of the metrics. So the first one, lead time. Initially, the scans, the time from a scan request going into the system to the patient being seen with the scan result and a management plan being given to them was about 20 hours. This is because most of these scans were being done on the next day. In our measurements over the last couple of weeks, we've seen two different pathways for patients into the system, and therefore I've timed them differently. So the first time of 15 hours is for patients who are seen on the surgical assessment unit out of hours, who are brought back the next day for an ultrasound. So the average time between a scan request and the report being given to them was about 15 hours. The second stream is for patients who are seen on the ASC in the ambulatory clinic and have a scan requested for the same day. That obviously markedly shortens the time to about 3 hours. I think there's a third stream that we've not captured here. That's for patients who are seen in the ambulatory clinic and then brought back for a scan the next day. That will obviously be the longest metric in terms of time. We've not specifically targeted this time, the lead time in this RPIW, because we didn't think, the general thought was that this time was useful, so it gave patients a bit of time, and the ability to reassess them in 24 hours was found useful by the surgeons. Also, it's important to understand that we're talking about ambulatory patients who are clinically very well and are not thought to be at risk of deteriorating if they wait for a scan. So anybody who was not fit for an ambulatory scan gets admitted and gets more urgent investigations done. So these are well patients who are fit enough to wait for the next day. So the lead time wasn't a specific target for us. Very happy to report that one of the big issues that we were having was scan requests being rejected by the ultrasound department. We've gone down from 33% down to 0%. So in the last 2 weeks, out of 79 requests that have gone through, none have been rejected. We were seeing a higher number of rejects because the requests didn't always fulfill the criteria that the ultrasound department had given for these ultrasounds. I'll speak a bit more about in detail about this in when we come to the newspaper. Again, in terms of staff surveys, the feedback has been excellent. 8 out of 9 staff have agreed that we've made progress and they're happy with the service that we are providing. Next slide, please. With the newspaper, with the first two processes here, the first process was about creating a handout, a leaflet that details the patient's journey and their preparation details for the scan. We have these printed and they're available on Ask and SAU, and they are being handed over. We were a little inconsistent in handing them over in the first 30 days, but that's improved. The next step is to get them formally printed through medical illustration and then have a formal leaflet that is handed out when ultrasound scan requests are made. This has had a positive impact on patients knowing where to go, what to expect, and also on their preparation for the scans. Next slide, please. So number 3 is the point that I wanted to elaborate on. This is scan requests that do not meet criteria. So in our pre-workshop surveys, we found that the highest number of dissatisfaction among staff in the surgical side and the ultrasound side departments was regarding a specific cohort of patients. So these were young female patients with lower abdominal pain who were clinically otherwise very well. And we had slightly opposing views from the surgical side and the radiology department, where regarding whether or not a scan made any difference to the outcome or to their management plan. What ended up happening was that when surgeons or the surgical team made ultrasound requests, they did not always fulfill the criteria that the ultrasound department had, and therefore the scan requests were rejected. Unfortunately, on a number of times, patients were sent home expecting a scan the next day, only to come back to find out that the scan request had been cancelled, and obviously that led to a very poor patient experience and some friction between the departments as well. Working on the RPIW, we developed an alternate pathway for these patients where they were given a delayed scan if their symptoms persisted for more than 24 to 48 hours after their initial presentation. This led to a significant drop in scan requests being rejected. However, this work has since evolved more in collaboration with the gynecology and urology departments, with establishment of a same-day emergency care service. We have expanded. These patients are now going to be offered slots. The only capacity we have is at Seacroft, unfortunately, at the moment, but we're struggling. We're trying to increase ultrasound capacity for these patients so that they are seen by a multi-speciality team to help them with their symptoms. This is ongoing work and will continue. I'll keep updating as we progress along it. Next slide, please. I think that's yes. The same day scans. As I just mentioned, they're very quick to get. Not all patients are suitable for same day scans. Our lead time for them is about 3 hours. The only restriction to a same day scan is of course a scan slot availability, but more so preparation for the scan, because some scans require a 6-hour fasting period and they're not always suitable to be done on the same day, which leads to a next day scan and a longer lead time. I think that's it. I'm happy to take any questions.
Thank you so much. That's fantastic amount of work that's been undertaken. Has anybody got any questions? No questions. Jimmy.
Thanks, Lisa. Thanks, Aman. Really appreciate that. I hadn't seen the data. I was really keen to see the data, having been involved in this event, and really pleased to see that hard work that I know you and the team have persisted with in really challenging circumstances, as we know, has really shifted the dial in a significant way for our patients using this service, and also, as you've highlighted there, for the colleagues who were doing their best and perhaps frustrated by it at times, if we're honest. I just wanted to highlight for those less familiar what you've just described around the contribution from colleagues in gynecology and urology. That's well without the boundaries of this original piece of work. And I just want to highlight that that's it's a real example of how people committed to this get stuck in and then ask and are provided with support to really develop the best pathways possible. I'm hearing that's not a done deal. There's still a lot of work to do with it. But from a situation where you described there was an opposing view and a little bit of a perhaps entrenched perspectives there, which meant the patients perhaps were falling through the middle sometimes, if we were really honest, to a perspective where we've now got more colleagues involved to really think about how we provide the best possible care. I just think it's worth reinforcing. So it's a thank you and well done from me. And hopefully others appreciate the extent that has taken from you and the team to persevere with it. There's more to come, but that's a great piece of work to hear about. Thank you.
Yeah, thanks, Jimmy. And I guess we didn't appreciate all of that hard work in the background, or those discussions I imagine have been challenging and lengthy at times to work through. But no, that's brilliant. Thank you.
Thank you, Jimmy. To that point, I would like to extend thanks to the team also. We all know the hospital has been really busy. SAU specifically has been really challenging for the past few weeks, and the team have been able to go beyond what they normally do and help with data collection also. So big thanks to the team also.
Janice?
Thank you. Amanda, actually, I really wanted to just reflect back, really, to be honest, what Jimmy's just said, but because I think what's really interesting there is picking up the amount of teams and across the different specialisms, CSUs, etc., that you've had to do this collaboration and working on. But it shows where we can continue to work on the process, that actually it can be so much better experience for the patient, recognising exactly as you demonstrated, one size doesn't fit all for our patients, and it would need to be quite different. And I think I found that very interesting. I work within adult therapies, and we work across many of the CSUs. Found that really interesting to reflect that to our own area. So thank you for a very interesting presentation. I look forward to your next report out. Thank you.
Thank you. Yeah.
Thanks, Janice. Amanda, on reflection now, do you think, from what you've been through the process and what you're learning all the time, do any of the concepts, any of the principles, would they lend themselves to other diagnostic tests, do you think?
I think, yes, certainly this can be rolled out to CT scan, definitely. I think when we first started, we were finding that ultrasound was more of a problem for the ambulatory service than CT scan was. So we wanted to focus on this. But certainly, yes, with other diagnostic imaging modalities, that should easily be applicable to them also.
So that sounds really exciting as well, because I do recognise how pressured SAU is, most of the time, I guess, so I guess any of this work really does lend itself to support and alleviate some of those pressures. Absolutely, yes. I mean, just finally from me, it was really good to hear about the patient and staff feedback. Just from a staff perspective, again, is there any other reflections from staff? Have you had the opportunity to ask them around their thoughts? How what do they see the next steps are going forward, or the opportunities? I think, yes, one of the suggestions that I was going to make to the KPO team was, especially if we are going to continue to do these virtual RPIWs, I think they should come with predetermined dates for team catch-up also, because I think the biggest problem I've had is trying to get the whole team together for follow-up afterwards, because not everyone is allowed, because of COVID restrictions, going into other areas of work. So it's been really difficult to get the whole team together, and if it's always been me trying to kind of meeting up with smaller groups
In answer to your question, Lisa, sorry, no, I don't think we've had the whole team together to discuss where we should be going, because we've just not had that opportunity to be together again.
Yeah, I fully recognise the challenges, and I guess, I mean, you know, certainly myself and Phil, Wood, the medical director, have been talking about principles, you know, going forward, because we recognise the challenges people are having meeting, etc. And I guess for the foreseeable future, certainly through winter, the virtual world will continue. But no, I appreciate, and I guess thank you for all that you've done, given the challenges so far, to keep the work going. Jimmy, you want to come back in?
Just thank you, Lisa. Just to acknowledge that from a man, yeah, I think we appreciate the post-production of an RPIW is a really important element, and I think what this work alongside others has really reinforced is it's even more important if you're delivering things in a virtual environment. And we didn't get that quite right from a KPO perspective this time. And it's a really good piece of feedback and learning. So yeah, I think acknowledge it and say, yeah, that's part of our next steps. So the next events, which will come, and they will be virtual, we've already got some penciled in, and they will include protected time as best as possible for the majority of the team, to keep the momentum with the work. And again, I'm just going to credit Aman and the team there for the effort they have put in to do that, even though we perhaps didn't give them the framework that would have been helpful. Yeah.
Thanks, Jimmy, for those comments. Yeah, okay, thank you so much for taking the time to come today, and to Aman and the team, and there's others of your team are on today. Thank you for all your hard work in what has been exceptionally difficult times. We're doing the very best we can, certainly for our patients, and really look forward to the next steps and how things progress. And if there's anything that we can do to support that work, then please do let us know. Thanks, everybody. That's a fantastic report. Have a fantastic weekend and a good afternoon. Thanks very much.